Hello, I'm Jim Werner with Case Western Reserve University in Cleveland. And we talked about in our ECHO series using motivational interviewing to help patients manage hypertension more effectively. And there were some questions about motivational interviewing, and I wanted to do a quick little review session today about those skills. And didn't really have enough time to do a thorough job of that today at the Echo session. So I wanted to provide this little bonus presentation to you. I'll just minimize my screen here, move it over. So motivational interviewing, as one person said in the feedback from the last session, it's hard to do. And it's like learning a new language, and practice does make it easier over time. It is challenging though. Um, and so, it's difficult to learn quickly, and it's also a little difficult to teach quickly. But I'll do my best today to add on to the presentation that I did earlier in this Echo series. So what I would like to do today is really touch on the spirit of MI and some of the specific steps that we talked about during the session that I did last month. And then I'll finish by sharing some interesting findings from a study of motivational interviewing. So why motivational interviewing? So who's it for? It's best suited for patients for whom health behavior changes are needed to improve their health, but the patient is not taking action to implement those changes. For patients who are ready to take action and make changes, in recent years, MI has encompassed planning and implementation, although I didn't discuss that in my first presentation. There are other implementation methods such as SMART goals and solution-focused brief methods for patients that are ready to take action. I use the solution-focused methods a lot in my work in the weight management clinic. The thing is that it's pretty common for patients who are making changes to then later slip back into an earlier stage of change. And I'm sure you all see that in your practices. For this reason, it's useful, it's always useful to know how to use MI. The rationale behind MI is that people feel ambivalent about changing behavior when other motives conflict with taking action. It's important to remember that ambivalence is normal whenever anyone considers making a health behavior change in which there are benefits on both sides, that is, benefits to not changing and benefits to changing. Ambivalence is a central construct or a central concept within motivational interviewing. We're trying to help patients resolve their ambivalence. And it is expressed in what we call change talk and sustain talk. An example of change talk would be, change talk, I know that I need to cut down on my salt. And sustain talk would be, but I've been eating salty food all of my life. Most people work through ambivalence more effectively by being listened to rather than having someone try to convince them that they need to make a behavior change. If it was that easy, we wouldn't have so many health behavior issues with patients. If someone could simply just tell them what to do, and logically it would make sense, and then they would just go ahead and do it. It's more complex than that, certainly. So the process of using MI is really facilitating behavior change by guiding the patient rather than directing them or giving advice. And remember that guiding can also be a lot less stressful for the clinician because you don't have to persuade the patient or solve the patient's problems. Your role is really just as a facilitator to uncover the patient's motivation and guide them in resolving their ambivalence. So move to the next slide. So MI emphasizes expressing empathy and understanding, and this is mainly done through reflective listening. It's also important to support the patient's confidence and optimism in their ability to make the behavioral change. And when resistance is encountered, we roll with it rather than push directly back against it. So, the steps to motivational interviewing that we talked about in the original presentation were to use the opening the door technique that Dr. Rao has developed. And it has 4 steps. The first is to express concern, such as, I'm concerned about your salt intake, and then to link that concern to the patient's medical problem. Too much salt puts you at risk for worsening blood pressure and many other health problems, for example. Third step is to solicit mutual concern. Does your salt intake concern you as well? And the fourth step is to collaborate. Are you okay discussing your salt intake for a few minutes today? So that's how we open the door to this conversation, whatever the target behavior may be, whether it's smoking cessation, weight loss, medication adherence, salt intake, uh, blood pressure monitoring. It's all, this works for all of those and more. So if the patient is not receptive, roll with the resistance. And this is most easily done by reflecting back what the patient just said, and then being ready to shift your approach. And again, pushing usually leads to even more resistance, because when we push, patients push back. Whereas making reflections usually causes patients' resistance to actually decrease rather than increase. So if a patient is receptive to talking with you about salt intake in this case, request permission then to ask a question. This would be a scaling question, 0 to 10, to assess importance. And this is really getting at trying to enhance motivation, help the patient identify their motivation and enhance that even more. So on a scale of 0 to 10, where 0 is it's not at all important for you to decrease your salt intake, and 10 is it's extremely important, where would you put yourself? Which number would you choose? And then the next question would be, I'm curious, why did you choose that number rather than say a 2 or a 0? And then they can talk about their motivation. It's a good opportunity to say, what else puts you at a 7, for example? And what else? Because we want to pull out all that motivation, let them remember it and get in touch with it again. Okay. And then we can ask about increasing the importance by 1 point on the scale, what it would take to do that, what that next step would be in increasing their motivation towards making a change. And a good way to ask this is to ask, how could this be an even higher priority for you? Say to go from a 7 to an 8. And then again, listen and reflect the patient's response in the same way that I just talked about for the first question. And then you can ask the patient if the step that they have identified through that second question is something that they're interested in working on. Okay. So that's our kind of our formula, so to speak, for motivational interviewing. Um, there's much more to it than this, but this is adequate. This is a good start, and this is enough to work with to help patients make behavioral changes. So you don't need to necessarily understand the whole universe of motivational interviewing and all the possible techniques you could use. This gets right at the heart of it. So I encourage you to use these methods with your patients. Okay, next, I wanted to share with you a study that sheds some light on the use of MI by primary care doctors in community practices right here in Ohio. This was a study I did some years ago. And we conducted this study to try to determine the extent to which PCPs, primary care providers, use motivational interviewing in everyday practice. And the target here was smoking cessation, but it could have just as well been salt restriction or physical activity or weight loss or medication adherence or something else. Okay, so the purpose, again, was to determine the extent to which these MI adherent behaviors were used by a diverse sample of PCPs. And they were told only that the study was to record conversations of encounters or visits to do some research on general communication between doctors and patients. So they were not tipped off or biased to use motivational interviewing in any way. Um, and then, we did not provide any form of training or intervention during the course of this study. It's very important to note. So we really wanted to look at what's the state of usual care with respect to uh, behavior change counseling in primary care. Okay. All right. Move to the next slide. So our methods in this study were that we analyzed audio recordings from 73 physician-patient encounters of smoking cessation that took place um, in routine visits to 21 Ohio-based primary care doctors. Excuse me. And we evaluated then what the physicians said in order to determine their degrees of adherence and non-adherence to MI, what they said during the visit to the patient. And for this, we use the motivational interviewing skills code, which is a behavioral coding system that's a validated tool. Okay, let's look at the findings. So here they are, and on the left half of the table, it shows the things that the physician said during these 73 smoking cessation discussions that were consistent with motivational interviewing. And the right half of the table shows the things that they said that were not consistent. It's interesting that 56% of discussions had at least one statement or question that exemplified an MI skill. On the right side, we see that 57% of discussions also had at least one statement or question that ran counter to the spirit and skills of MI. So it's impressive that without any study-related training, the physicians used MI adherent skills as much as they did, but they also used MI non-adherent skills, or things that they said were non-adherent to MI, and usually directly in opposition to the spirit and skills that are used in MI. Okay. In 31% of discussions, and I'm going down now on the left side, they affirmed the patient's strengths. In 22%, they supported the patient with empathic statements. In 19% of discussions, they requested permission before providing advice. They emphasized the patient's autonomy or their own decision-making capacity, that this is their choice, their decision to make these changes in 10% of visits. And they asked permission before raising a concern in 3%. Going further down, they also pretty frequently asked open questions and made simple and complex reflections. Those are all MI adherent behaviors. Over on the right, on the non-MI consistent side or adherent side, they directed patients in 30% of discussions, and this is just simply telling the patient what to do. Confronted them in 25%, and this is a much more confrontational approach of saying, you need to change your behavior. This is a serious situation, for example, or confronting them about, why haven't you quit smoking, etc. They didn't ask permission before raising a concern in 23% of visits, and they warned patients in 22% of discussions. And warnings are, if you don't stop smoking, you very well might get lung cancer, or you're on the path to emphysema or something along those lines. They gave advice without asking permission first in 15% of discussions. So the good that was done as a result of the MI behaviors on the left side may have been diminished by the non-MI behaviors on the right side. So there's an interesting quote by de Saint-Exupéry, who was a famous pilot and writer, and it's a well-known quote. Perfection is achieved not when there is nothing more to add, but when there is nothing left to take away. So we'll kind of keep that in mind as we move ahead. Based on these study findings, it might be that in your practice of MI, the focus should actually be placed on what needs to be removed rather than what needs to be added. You may already be doing a lot of the things on the left side, um, but we don't want to undermine those things by also doing the things on the right side. So I invite you to reflect on your own clinical work and recognize when you use MI adherence skills and give yourself credit for doing that. You're really making a difference in the lives of patients. These are evidence-based practices. MI is a evidence-based method, and you're very likely to be helping patients move down the path towards making positive changes. At the same time, I encourage you to look to see if some of your hard work might be undercut by using non-MI behaviors without even realizing it. So removing certain things may allow your good work with patients to shine even more. Okay. Thank you. It was a pleasure working with all of you during this ECHO series and hope to see you at the next one. Take care.